today. It is certainly a topic that generates, wherever I go, great conversation and great interest. So today what we'll be doing is doing kind of a brief, semi-random overview of some things that I think would be helpful for you to know about opiates, the opiate epidemic, some of the ways that we're approaching treatment, some of the context for how we got here. We won't be covering things super in depth, but I want to give you some good ideas to answer questions or to ask questions. We're certainly able to take them during the webinar. If you email them to Carmen at mhrbuc.org, then we can even respond to them by email, or if there are resources or links that you would like, we can post them on the Ohio Council of Family Relations website. So I appreciate being invited to do this. I think the turnout and the registration for this is far exceeded our expectations. And so I hope you find this information useful. Please feel free to ask questions through the chat box, and we will try to get those answered throughout our presentation. Just a little bit about our organization in terms of who we are at the Mental Health and Recovery Board of Union County. We are one of 52 or 53 local or regional planning authorities for behavioral health services. So we are a separate political subdivision of county government, so we are self-governing. We have board, 14-member boards that of local folks who live in the jurisdiction, who guide the activities of the boards. Many of you probably in your communities have interfaced with ADAM boards or mental health and recovery boards, but I wanted to talk just a minute about some of our duties, and really our primary duties are assessing communities and identifying needs for behavioral health services across the continuum, from the most universal prevention services to the most intensive treatment services and beyond. We are a funder. We are not prohibited by law to provide direct care services to clients, but we contract with local certified providers to do so on our behalf. So we also have a function that is extremely important, and that is protecting client rights and making sure that people are treated ethically and fairly when they receive treatment services in our jurisdiction. So I've included a map on this second slide of the different board jurisdictions. As you can see, some are single county boards like our Union County Board, some are multiple jurisdictions. I think our largest is in the Coshocton, Muskegum areas of 6 counties. So, but at the web address on this slide, this map is interactive. So if you go to that web address and click on the little icon on the left-hand side of the page at our association website, it'll link you to your local board. And if you're not familiar with who they are, they certainly are a potentially great partner in your work. I knew, and through not only my experience, but also what was happening in our communities, that family systems work, not just in a therapeutic or clinical setting, but family systems and family education work was really critical to us combating this opiate epidemic, because we can't treat our way out of this epidemic. It is the casualties are just too high. We have to go back to the beginning of the continuum and actually look at universal strategies and family strengthening and individual strengthening programs and approaches that can assist us. So I encourage you to check out your local county authority and see how you can connect with them if you haven't already. I wanted to set the context a little bit for where we are and how did we get here. Carmen is acknowledging that my camera's not on. I'll just let you know that I'm extremely handsome, and so if you, we'll just leave it at that. So I don't know how to make this camera thing work, so So I need to start my video according to our host.
Initials for their website again.
All right. Well, we're gonna go on for the interest of time. So let's see. All right. I wanted to set the context a little bit about how we got here. There I am. All right. I kind of lied about the handsome part, but to say how did we get to this opiate epidemic? You know, I'm entering my 30th year in behavioral health. I started in substance abuse prevention and substance abuse treatment, and it's a very different landscape now than it was 30 years ago. When I started in kind of a rural county, in rural Hancock County, I had one heroin addict, and he was a holdover from kind of a Vietnam era veteran who had become addicted while he was serving in the Vietnam conflict. And so that was kind of what we saw. And people who used heroin were considered kind of the skid row, very deep end of the continuum, and not very frequent. So we got here not by accident, actually. There were a couple of things that really converged to bring together kind of the perfect storm for us to create an opiate epidemic. The first thing was that we are now trying to move the slide. There we go. In the late 90s and early 2000s, the healthcare systems, particularly things like the Joint Commission, who accreditates hospitals, started looking at people's pain and the treatment of pain as the fifth vital sign. So, you know, you have your blood pressure and your temperature and your pulse and all of those kinds of respirations, all of those vital signs. They started looking at pain as the fifth vital sign, and treating pain was given a lot more attention. So many of you have probably seen this little pain rating scale. It came out about this time. And if you go to a primary care physician or you know, a hospital, chances are you're going to get asked, even if you don't present with a pain issue, where your pain is on a scale of 1 to 10. So this pain rating scale really supported the pain as the fifth vital sign. So around that same time, the Joint Commission was looking at their standards, and they accredit everything in a hospital from the temperature of the rooms to the charts to, I mean, it's a very extensive process. And they started including in their standards around pain management, patient satisfaction around pain. So when you get a survey, you go to your doctor, you go to the emergency room, and you get a survey that says, how satisfied are you? The hospitals were rated on how well they treated your pain. And hospital ratings were extremely important because they're really tied to reimbursement and certification. So hospitals definitely wanted to make sure that you were not hurting when you left. So that you were taken care of and that their patient satisfaction scores would not suffer. So at about the same time, the pharmaceutical industry is introducing some new types of pain relievers. So we saw the emergence of oxycodone and you know, OxyContin. So we saw synthetic opiates come into the market, and they were presented to physicians as being non-addictive and as being safe for prescriptions in large amounts. And so we had this perfect storm of kind of the pharmaceutical industry and the pain management industry and hospitals kind of convening to create convergence of events. Just on a terminology thing that sometimes people miss, we use the term opiate and opioid. Opiates are the natural versions of opiate medications, things like heroin that come from opium poppies, and they're the kind of the naturally occurring in nature piece of medication. Opioids are the synthetics, and opioids were the ones that really took off in the early 2000s. So again, it was kind of a perfect storm. On the average day in the US, about 650,000 opioid prescriptions are dispensed. We're going to talk a little bit more about that. Almost 4,000 people initiate non-medical use of prescription opioids. Again, so this is really why we can't just clean up the mess. This is why we can't just focus on treatment. We have to focus on prevention because every day, thousands of people for the first time use opiates and opioids. Even if they're prescribed, they use them in a non-medical way. They may take more than is prescribed. They may take longer than is prescribed. They may take other people's prescriptions. Every day, 580 people initiate heroin use, and we have about 80 deaths a day from opioid-related overdose. So it really has become truly epidemic. We focus a lot in our work, and I know you focus a lot in your work about children and young people. So it's really important to know that people rarely go from non-use of opiates or opioids directly to heroin. They very often will start with prescription painkillers, either their own or someone else's. And that's kind of their initiation. The trajectory is shortening now from the time that people initiate non-medical use of prescription painkillers to heroin use because of heroin's availability and the very expensive nature of prescription painkillers compared to heroin. So, obviously we're very concerned about initiation of use, but more than half of our kids are starting with prescription painkillers. And while this really isn't necessarily about other drugs other than marijuana, this is really an important statistic from the National Survey on Drug Use and Health, the sources on the previous slide. The people with substance use disorders typically don't start out using opiates. They start out using other things. They start out abusing alcohol. They start out using marijuana before they turn to age 18. And so we really are concerned kind of holistically about giving kids good skills to protect them from initiation of use. So in America, kind of the opiate picture is there are about 20.5 million people in our country who are living with a diagnosable substance use disorder. So that could be anything from alcohol, which is by far the most prevalent, to cannabis use disorder, to other types of use disorders, cocaine, and all those things we think of. Of that 20.5 million, about 2 million of them are diagnosable of having a substance use disorder involving prescription pain relievers. And about 591,000 of them have a substance use disorder involving heroin. So, in the grand scheme of things, it's a relatively small amount of people. When you consider the population of 350 million people in the United States, I like to think of those 591,000 people. That's the size of Milwaukee. So it is as if the citizens of Milwaukee have said, we're kind of taking over the country because of our use disorders, and indeed, dealing with opiate use disorders has really hijacked the behavioral health system in terms of its cost, in terms of its intensity, and certainly when resources are limited, it means that other people with other kinds of disorders probably get less attention. I certainly know that that's the case, and the ethical distribution of resources is probably the most difficult part of my job. Because statistically, we're dealing with a fairly small population, but one that requires a lot of intense resources. I'm not going to read on this much on this slide, but I do want to just draw your attention to one fact here, and it tells a little bit about how we believe about the efficacy of medications in the United States. America has less than 5% of the world's population, but consumes 80% of the world's opioid supply. So there's clearly a demand, and nobody likes to be in pain. Nobody likes to see a family member in pain, but we have developed a culture that says kind of pills are the answer, and it's if we take something, and that's kind of the beginning and the end, is that we take a pill and we're better. And we have been that worldview has been very much created and supported by the pharmaceutical industry. This is, I think, a 2014 statistic. This is the doses per capita for opiate and opioid pain medications in the state of Ohio. You can see that for every man, woman, and child in the state of Ohio, the doses per capita is 66.7 doses per capita. That means that if we spread out the opiate dosing to every man, woman, and child, they could get a pill bottle with 67 pills in it, which is just absolutely staggering when we consider what we know now about this. And things are trending a little bit better in terms of how we prescribe. We'll look at that in a minute. But that's a really staggering statistic. And there are some counties that are a little better than others. We saw in Southern Ohio legislation around pill mills. There were pill mills that were prescribing opiates rather indiscriminately and unscrupulously. And then, we saw pill mill legislation come in that shut those pill mills down. And then we saw the spike in heroin. Excuse me, I'm going to take a little swig of my water. I promise it's not an illicit substance. Just a little bit of contrast in the last, 15 years or so. This was our age-adjusted death rate by drug overdose in Ohio and in the nation, by deaths by opiate per 100,000. So our death rate was 4.2 people per 100,000 in Ohio were dying of opiate overdose in 1999. This is a statistic. This is the same slide updated through 2014. And we see that has jumped from 4.2 per 100,000 now to 24.6 per 100,000. So 6 times the number of deaths per 100,000 average than we were just 15 years ago. So you can kind of see that Ohio has ridden the crest of the wave of the perfect storm and made, unfortunately, it's moved us to the head of the pack. Ohio is one of the called the ground zero states for the opiate epidemic, and it's really something that we really don't want to be first at. So big problem. The Ohio Department of Health just recently released some of the opiate overdose and kind of opiate information that they collect through 2016, and you can go on the Ohio Department of Health website and look for some of their news releases on the opiate issue, and you can see the adjusted death rates per 100,000 are, we see kind of where the hot spots are. The white counties are for rates that were not calculated. So if they had in the 5-year span fewer than 10 deaths by overdose, they were not calculated to protect kind of the epidemiological privacy of those folks. But you can see that some places are extremely hard hit when we look at Brown County at 41 deaths per 100,000 and Gallia County at 25, and it's just really devastated us. We've been fairly fortunate where we are. We're one of the lower ones in the state, and that's great. That's wonderful. We'd like to think it's that there are things that we're doing that are making a difference. But I can tell you that folks are working really hard in those other areas too, and whatever kind of economic and socio-demographic factors kind of combine to make the environment more susceptible to opiate addiction are just not in their favor. Um, because you folks typically work with families and kids, I wanted to talk a little bit about some of the costs in terms of child welfare. And the Public Children's Services Association of Ohio puts out every year, every other year or so, a fact book that you can download on their website. I put the link there, and it is really a great resource. It's great for grants if you're a grant writer, but it profiles child welfare issues by county, and and these statistics I thought were really compelling. When you see more than 75% in some of our counties of the child removals are due to opiates. And that has certainly had a toll not only on cost in terms of the cost of placements and the cost to the lives of our little kiddos, but it's had a big cost in terms of the impacts on our workers. And we see that kind of across the board with our workers who are on the front lines, our therapists, our law enforcement, our child welfare workers, our teachers and first responders. Are really suffering vicarious trauma and a lot of compassion fatigue. And we're starting to take that more seriously now as a state, and how we can really bolster some of those concerns. Many of you will remember probably maybe a year ago now, there was a picture from an Ohio county that made national news of a grandmother and I think her boyfriend, who were passed out, overdosed in the front seat of a car. And there was a 4-year-old in a car seat in the back seat, and it was so compelling. And a lot of my colleagues, when we would have discussions about that, talked about the concerns for the child and concerns for the folks who'd overdosed. But I really argued that not only do we need to be concerned about them, but that picture itself, published by, I think, a local law enforcement officer, was a symptom itself of vicarious trauma and frustration. Like, this is, communicating a strong message that our folks are very, very traumatized by having to deal with this over and over and over again. So we've done some good things in terms of how we have addressed the prescription opioid issue. You'll see that as of 2016, again, this is from the Ohio Department of Health, and there's the link. Our prescription deaths by prescription opiates are decreasing. I'm going to flip real closely next to a slide. That's partially because of our prescription drug monitoring programs, or PDMPs, in Ohio. It's called ORS, which is the Ohio Automated Prescription Reporting System. And so you can see that we have decreased significantly the number of doses that were prescribed. It's still 625 million or so. But we have reduced that significantly. Unfortunately, as we're doing this, we see the spike from this new thing called fentanyl and carfentanil. Fentanyl has actually been around for a while, but carfentanil is kind of a new derivative of it, and they're extremely deadly, and very, very minuscule amounts can cause overdose. You may have seen the news story about an Ohio officer who accidentally, during an arrest, got some fentanyl on his uniform. It was the white powder. He just naturally brushed it off and actually overdosed and had to be revived with Narcan because just that much of it was so deadly. So, where we have seen extreme hotspots in terms of opiate-related deaths, that has pretty consistently been due to the availability of fentanyl in a particular area. So, very, very difficult to stay ahead of the game. I just wanted to include a few things on some of the opioid misuse and dependence things. Obviously, we notice some physiological changes that occur. People have changes in appetite. We look for opiate intoxication withdrawal, some pupillary response, but the withdrawal from opiates is really wicked. And people can die from opiate withdrawal. They tend not to die from opiate withdrawal as frequently as they do from alcohol withdrawal, actually, but they do feel like they're going to die. And so, not only do we have this thing that has changed my brain chemistry that I've been using, we have a substance and an experience that's very classically reinforcing. You feel like you're going to die. You feel terrible. You feel like you have the worst flu you can possibly think of. And so it's very unpleasant. We are really looking at how we structure withdrawal management now, which is what we're calling detox, and how we have access to that. And Ohio has made some really great strides in trying to increase capacity around that. Both with federal and state dollars, but definitely it's a very just unpleasant thing, and many of our folks are withdrawing in jail cells. So we really try to make sure that we can make that experience less unpleasant, so it's not so classically reinforcing, so that people say, okay, I can, we've managed this withdrawal. It was, I lived through it, and that can hopefully set me on a trajectory to recovery. The 3 C's of addiction, this is a classic, and I don't think Vanis in 2010 was the first to do this, but he just happened to be a great source for it. But we talk about the 3 C's of addiction in terms of loss of control, and from initiation of use to emotional first, and behavioral loss of behavioral control, getting those cognitive distortions, which would be things like denial and minimization, and it's really not a problem. And then finally we see some of the physiological symptomology emerge with tolerance and withdrawal. And so obviously that loss of control leads to the compulsion, which is drug seeking and craving. Again, opiates are wickedly reinforcing in terms of craving, and so folks get very, very motivated to use despite adverse consequences. And many of our folks tell us that we know that this is it's not that they are so cognitively distorted that they don't see that there are issues, but that the physical and the physiological compulsion is just so strong. And then finally, chronicity, that we have many, many relapses in terms of on the path to recovery, and relapse is possible even years after sobriety. One statistic I saw recently was that at 4 years of recovery and sobriety from opiates, folks still have about a 25% chance of relapsing, which is just incredible when you think about how difficult it is to maintain sobriety from an opiate for 60 days, let alone 4 years, and still have a fourth of the folks will relapse. Some of the treatments that we are using now have really changed and moved us ahead in the treatment of opiate use disorders. The opiate user is a different kind of addict than we have seen in the past. One of the things that we know is that when we talk about the 3 C's, of addiction, traditionally those have been related with substances that have taken a period of time to develop. So, if you look at the trajectory of alcohol use disorder, you can actually see that, folks, that takes a lot of time to develop. You have to really work at it over a period of time. You don't take 2 or 3 drinks and develop an alcohol use disorder. It takes time. The thing that has caught us off guard and has rendered our traditional treatment as usual so ineffective is that the trajectory of opiate use dependence is so truncated. It is so short. The window is so small. There was a recent study that I saw that that risk for continued use starts to emerge at 4 to 5 days. They see increased risk of opiate use, which is, when you consider That's people often leave the emergency room with a 30-day supply of Percocet or OxyContin. That's really shocking. So treatment as usual has not worked with our opiate addicts. They have a different characterization, and we'll talk a little bit more about that. Fortunately, however, we do have FDA-approved drugs to use in medication-assisted treatment. Medication-assisted treatment now has become the standard of practice for treating people with opiate use disorders. It wasn't without controversy. I've been in this business a long time, and abstinence only was kind of the prevailing wisdom, the traditional wisdom that you went to a 12-step program, you were abstinent, you didn't use other drugs. I still hear when I talk to folks isn't this really just kind of substituting one drug for another? And I have to say that, when it comes to such life and death, such a life and death condition, all bets are off, and we have to stack the deck in the favor of our addicted folks as much as we possibly can. So there are three primary categories of FDA-approved drugs used in MAT. Methadone has been around a very long time, and you have to have a special opioid treatment program. It's usually a clinic. They're typically found in larger cities. Folks often dose daily, excuse me, at the clinic. And so they're few and far between. We're finding we're finding that there's a resurgence of methadone as a strategy, but it's certainly not widely available in terms of treatment strategies. Buprenorphine are things like Suboxone, which is what we call a partial agonist. So methadone is a full agonist, meaning that it meets the receptors in the brain exactly like an opiate. So it's exactly the same. It binds to those mu receptors just like any other opiate. The advantage of methadone is that it doesn't have quite the high, and people are able to function on it much better. Buprenorphine or Suboxone is a partial agonist, means that it only covers some of those receptors, and so you don't quite get you get less of a high, but you don't get, it reduces the craving. So, and that's Suboxone, you have to have a specially certified physician prescriber who has a waiver that they have to sit through and do classes and do a certification exam and a few other things. So Suboxone is also fairly recently available as a transdermal implant right underneath the skin that can be done every 6 months. Naltrexone is known by the brand name Vivitrol, which is actually produced by an Ohio-based pharmaceutical manufacturer. And so it is actually an injection. There's an oral formulation that folks typically start with to make sure that they tolerate it well before they have an injection called Brevia. But very quickly then folks are getting into the injectable. It's a once-a-month injectable. It's extended release, and it's an antagonist, meaning that it completely blocks the effects of opiate on the brain. So it doesn't bind to those receptors, it actually blocks them. So if folks would happen to use heroin or happen to use another type of opioid, they're not going to get any high from it, and it really reduces craving. And it's been a very effective drug. I will tell you, it's a very expensive drug. It's about almost $1,000 a month for an injection for Vivitrol. We've had very good luck with the company helping us out with sample doses and free doses and patient assistance programs. And fortunately, it is a medication that Medicaid will pay for. So just wanted to give you a little bit of insight on that. And so we're going to have to move kind of quickly because I'm a yammerer. So the slides will be available on the website, but I wanted to talk a little bit about the fact that, only about 10 to 20% of the folks that need treatment are able to get it, and particularly MAT. There are about 800,000 physicians in the United States, only about 33,000 of them have an MAT license, and only about a third of those folks prescribe because there's a lot of risk factors, and obviously it's not a population that everybody wants to deal with. So in looking at kind of the different type of addict that we are dealing with, addiction treatment services since the 80s have used the transtheoretical model of change, DiClementia and Prochaska's transtheoretical model of change, and you've probably heard of that. It's transtheoretical, so it's applied to a lot of different disciplines, and we start with pre-contemplation, where people are unaware through contemplation, and then people prepare to make small behavioral change and have that behavioral change intention to action in the maintenance. And we've typically viewed this as a very linear process. And our addiction treatment programs were designed on a very linear trajectory, so that people started to, we got them through, broke their denial, we treatment planned with them, we moved them to action, and then we put them in relapse prevention programming. So unfortunately, because again, the intensity of the craving and the physiological addiction, we see that now it is not a linear progression, but it is very, very kind of convoluted, and relapse can happen at any point. And so we have to kind of rethink how we approach our addiction treatment programs. So it's very difficult for families and family members to kind of understand the fact that, okay, well, they're doing so much better, why would they go back? And it's just a very kind of insidious relapse dynamic because of how we work through those stages of change. In many cases, and certainly not all, but in many cases, when we profile particularly our heroin users, they tend to be younger. And in that 18 to 25 to 26, although we obviously see it much older as well, but we see those younger folks who are addicted, and we have traditionally used a rehabilitation model in addiction treatment. That meaning that we want to rehab people and get them back to their former state of functioning. What we now know is that a lot of these younger people don't have prior state of healthy functioning to return to. So we're having to habilitate them and give them basic skills that they didn't, that they never developed, because of their addiction and their brain development. I'm going to talk a little bit now. I'm going to go through these kind of quickly because I want to make sure we have time for change about the kind of the definition of recovery, and that is where we really want people to improve their health and wellness and be self-directed. And that is a different way that we have tried to look at recovery versus treatment intervention, because we have typically looked at external controls for people being in treatment, and external checks and balances, and certainly those are important, and there's good evidence that compelled treatment is as effective in particularly in criminal justice circumstances as voluntary, but we really want to move those people to self-directed lives. So we're looking at things called like recovery management, and it's basically a philosophy for how we engage folks and how we organize their the supports that they need. And one of the ways that we do that is by looking at their recovery capital. And recovery capital basically are those internal and external assets that people can kind of parlay into a healthy, sustained recovery and life. And those are very different from person to person, depending on their family support, depending on their context, their own risk and protective factors. But just like individuals can have recovery capital, communities can have recovery capital. And that's why I believe so strongly in the role of family and really educating our families and educating our communities to be recovery supportive and to be communities where people in recovery can be deposited in an environment, an ecosystem that has a high amount of number of assets for their own recovery. We do this kind of through a framework that we call recovery-oriented systems of care. I mean, we're not going to have a lot of time to do this, so I'm going to go through slides fairly quickly. But it's basically a framework that we use that's very person-centered, and we really kind of try to acknowledge the person's chosen pathway to recovery. For those of you who are family systems folks and ecological systems theory, this is not going to be new to you. For those of you who have worked in kids, in the kids' mental health system, or in wraparound or integrated teaming with families and communities, this looks pretty familiar. But you know what? We blew it on the adult side. We had the technology that we worked with families, we worked with kids, and we just never really did a technology transfer from those types of younger kids services to adults. But we're finding that those are the things that really folks need. And people very often will say, I need to send my kid to rehab, treatment, they need to go away. And that's great, but it is one small piece. And in my mind, even though I run, I fund treatment programs and I have been a treatment professional, it's probably the smallest. Making sure that they have good, effective treatment is really important. But in order to build a life, those other parts of their ecosystem are equally, if not more important. Just let you read some of those things. In a recovery-oriented systems of care, we know that there are many paths to recovery, that professional treatment is one, non-traditional methods, medical interventions, faith, and we try to acknowledge that folks kind of build their own recovery path with the supports that they need. And the old wisdom was, wow, you go to 90 meetings in 90 days and you hit that, and that's great for some folks. Particularly our younger folks, they don't connect with that. They don't have the skills and the social capital to interact in those kinds of settings. So we need to make sure that we're getting them on the path that is really tailored to them. One of the new phenomenons that I think that would really be of interest to family life, folks interested in family life, are the issues of peer-delivered services. And we have in Ohio now certified peer supporters, and these are people who have lived experience. We have them both for mental health services, and we have them for alcohol and drug services. People with lived experience who have had some time in recovery, who take 40 hours of classroom instruction and 40 hours of online instruction and then an exam to be certified as a peer supporter, to kind of fill the gap for folks, and to be kind of that stand-in between, say, for example, a sponsor, maybe in a 12-step program, and a case manager, and also just kind of that moral support of, I've been there, I've done that, and it's really working well. There's some really great peer support programs, and very often our peer supporters need skills. They get that initial training, they get the certification, but they need skills. So as you're designing programs, these peers work very closely with people and families. They work very closely with people with children. Maybe they might need some parent education or just some strategies that they could then in turn use with the people that they worked with. Peer support's not without controversy because everybody is concerned about things like dual relationships and ethics and boundaries and those kinds of things. We had that same phenomenon when case management came into the mental health system. The therapists were all up in arms, and that people would be going to people's homes and transporting them in cars. Worked out fine. So peer support is really here to stay. And there are a lot of places around the state that are doing some amazing things with peer support. And certainly it is a place where we have tried to interface both with extension in terms of peer supporters for our recovery housing and doing parenting programs and nutrition programs and things like that. But also as a board, we tried to make sure that those family life kinds of things are represented. We're going to skip very quickly over some of these issues because I want to get to some of the questions that were ahead for us. And there were a number of questions that were submitted that, how does opiate use in the family affect kids? Many of you may be familiar with this kind of model of the survival roles that kids take on in addicted families. Sharon Mudshredder Cruz put this out in the 80s. It became a very, very popular paradigm for how we understood family dynamics in an addicted family, and it still really has some great utility. Even many, many years later. However, what we find in the opiate addicted family is that adaptive roles or survival roles, kids develop over time. So, a family hero may develop kind of caretaking traits because over and over and over again, the parent has been kind of absent because of their addiction or things like that. So, but unfortunately, with the very truncated time period from initiation of use to addiction being so short, that kids don't even have time to develop maladaptive survival roles. Now, I want you to think about that. Kids don't even have time to develop dysfunctionally in these environments because things are so chaotic and so intense and so rapid. So that really kind of changes the way we look at some of the kids and families that we work with. And so we have to think about how the risk factors that they're facing and their parents have faced kind of revisit onto them and create kind of a generational set of risk factors. And what we see very often is that kids are not in necessarily a dysfunctional role, but they're in a state of acute trauma. And so kids that are coming into our classrooms, kids that are coming into our Sunday schools, kids that are coming into our child welfare system are in a state of very acute trauma because things have happened so rapidly. And I think as people who provide information for families and kids and communities, we really have to understand the role of trauma and realize how widespread it is, and also to seek to develop programming that resists re-traumatization. We know a lot of times that the things that we do with sometimes the best of intentions can actually re-traumatize kids, and maybe in terms of the way they're disciplined at school, or maybe even traditional parenting strategies, may be re-traumatizing, where they might apply something from, say, active parenting, for example, might apply in a context where there's limited, dysfunction or a more healthy, stable family unit, might actually be traumatizing in the context of, that acute, those acute issues for those kids. I wanted to just give you a little idea about how we're trying to change the way we approach kids. We still require, even though we know that kids act out their pain, their grief and loss, they don't really talk about it. We still try to intervene by talk therapy. And Carmen and I were just at the National Rapid Round Implementation Academy and heard this Amelia Frankmeyer. She has a TED Talk on the human need for belonging. I really urge you to click on it. It's 18 minutes. That way you will come away and go, yeah, that's it. That's really great. So if you get a chance to look at that. Some of the ways that we are intervening with these kids are by trying to create more nurturing environments on purpose. And so we use a framework called the Nurture Effect, the Creating Nurturing Environments, from Dr. Tony Biglin out of Washington State. And there are basically 4 things that we try to do simultaneously: richly reinforce pro-social behaviors, reduce toxic influence, limit problematic behaviors, and increase psychological flexibility. So those are all strategies that we put into place through our Kernels for Life program, and I'm going to just skip very quickly through that and let you know that Carmen Irving is our resident state expert on the Kernels for Life program, and if you want to hear more about that, you can go to our website, www.mhrbuc.org, and look at the Kernels and PAC's Good Behavior Game information, or you can contact Carmen directly. So now I'm going to open it up for questions to see if we have any specific questions. So apparently I have either bowled you over or with information because it's been kind of a brain download. But I wanted to give you just an overview, a topical overview of some of the issues that we faced, so that you might spur some additional questions or some additional investigation that you might have, and look at resources. I really believe that people who work with families and understand family systems, like the people on this webinar, are uniquely poised and positioned to assist us in the opiate, the fight against the opiate epidemic, because you understand the complex interplay of environmental systems and ecological factors that go into making up a family or making up a person or making up a community. So, I would love to see family life educators be involved in things like our wraparound teams as supports for families, as perhaps providing their expertise to a recovery team or recovery coaches or peer supporters, because I think you have a very, very valuable product that is underutilized. And so I really appreciate your time and attention today. I am certainly willing to take questions via email, and we will turn it back over to Patrice, who will, or Carmen, either whoever is going to do the wrap up. Okay, we do still have 2 minutes. We did get an email question. Great, live from the studio audience. Couple of things. What city or county in Ohio is making the most progress to decrease opiates as a problem in their community? I think that it varies. We see some very promising practices in some very hard-hit areas, places like Claremont County, Montgomery County, Hamilton County. They're doing things like QRT, which is a quick response team, which pairs a peer supporter with law enforcement to really rapidly respond to people who have overdosed and really try to engage them in treatment. We're seeing some really great things happen in prevention. I like to think that Union County is a great place that we're doing some really great things on the prevention end, as well as treatment. So it really varies by the location. The next question was, are men being affected more than women? Statistically, men always outpace women in terms of substance use disorders. Women are, about 12% of the population of women are alcohol dependent, about 20% of men. And what we do know is that in the opiate world, men still outpace women, but we have some very unique, women have some very unique phenomena that happen in the opiate use, and one is partner initiation. We see a lot of women who initiate opiate use because of a male partner, a husband, a boyfriend, someone who actually initiates their use, and then their use takes on a life of its own. We know there was a study done, I think in 2015, maybe Hitchfield, I'm not really quite sure the researcher, that biologically women may be more susceptible to craving, and so they're trying to research out the differences in gender related to craving and initiation. And we also know that women benefit from different types of treatment. Women are typically more engaged in group treatments and kind of those supportive groups than perhaps men are.
How much research has been done on preventing compassion fatigue among professionals in law enforcement?
The question is how much research has been done about compassion fatigue in professionals in law enforcement. There actually is quite a bit of research out there on compassion fatigue and burnout. There are inventories. There's a burnout inventory that's that the author just escapes me right now out of my head. But there are things that we can do. I know our state, as a state, particularly after our conversations from that photograph that I mentioned, is having a lot more conversation about how we take care of our providers and our law enforcement. So there is quite a bit on compassion fatigue and burnout in the literature, and we're starting to see the research kind of build on that body of literature into specifically this opiate issue. Workforce development is probably one of our biggest hurdles because this is difficult work, and even people who have some sort of kind of missionary zeal and missionary calling to this work find themselves very demoralized by the process that they have to go through.
Are there any states that have successfully addressed the opiate epidemic, which can be followed?
Are there any states that have successfully addressed the opiate issue that we can look to? There are some states that have done things a little bit maybe more progressively in terms of harm reduction, and things like needle exchange programs that Ohio is just starting to get into. Obviously, states that tend to be more progressive socially and politically, are a little ahead of us on that. States like California, New Mexico, some of those areas. But Ohio being so densely populated and so intensely involved in this this initiative is actually where people are looking for a lot of their information. Good questions.
Can I steal your mic?
You can steal my mic.
I always feel like
Can they hear me? Good afternoon. Thank you so much for joining us today. I'm so pleased with the turnout we've had. Email questions are continuing to be emailed, but I recognize that we're out of time. Please feel free to continue sending those questions. Dr. Phil and I will sort through those and make sure that we address any questions that have gone unanswered for our next webinar. That webinar is November 30th from noon to 1. If you have any questions about that, please feel free to email me or check out the Mental Health and Recovery Board website at mhrbuc.org or the Ohio Council on Family Relations website at oh.ncfr.org. Thanks again for tuning in, and we'll see you next month. That's 2 months from now. Yeah, something like that. See you in 2 months. Take care.
oh, and the camera's still on.